Cool. Well, thank you. I am talking this morning about atrial fibrillation and heart failure, comorbid disease. I don't have any conflicts of interest. The things I'm hoping we can take away today are trying to understand the relationship between these two disease processes, kind of reviewing standard of care management for them together, look back over some of the evidence and data that supported kind of rate versus rhythm control strategies for managing AFib in the setting of systolic heart failure. And then lastly, go through a case of kind of the acute presentation of AFib with RVR in the setting of acutely decompensated heart failure. Caveats to this, I am definitely not a cardiologist. I don't intend to become a cardiologist. And this topic was actually born sort of out of trying to address some of my own ignorance. So hopefully you gain some benefit from the things that I have learned. I will also say that some of the nuances of the management of AFib and heart failure individually and kind of together are beyond the scope of this talk. And so I won't go into them. And then some of the kind of advanced cardiac therapies, CRT, AV nodal ablation, I will mention them throughout, but not dive into them at all. And then the last thing to know is just as with many things with heart failure, most of the data here deals with heart failure with a reduced ejection fraction rather than with preserved ejection fraction. And so you can see there's a statement from the 2022 AHA guidelines that said that primarily the data is drawn from patients with reduced ejection fraction. And at this point, most of the management strategies are based on the idea that we can extrapolate from that population to the HFpEF population. So let's dive in. So first, how many people have this? This is quite old data now, but the prevalence of just atrial fibrillation was somewhere between 3 and 6 million 12 years ago, with 46 million people having AFib worldwide. Looking back at the Framingham data, the incidence of atrial fibrillation in the general population increased three times over the course of 50 years. The prevalence of heart failure was 6 million, and then the global prevalence of congestive heart failure, kind of all-comer congestive heart failure, estimated to be between 1 and 3% of all adults. And then given that we're thinking about the overlap between these two syndromes, if you look at the 2011 data, this is 5 million Medicare beneficiaries with heart failure. You can see that AFib, while not the top co-occurring condition, is present in almost 30% of heart failure patients. So why does it matter? I picked this in part thinking about the fact that these are, so as we'll see on the next slide, heart failure and AFib kind of come out of common risk factors, and they potentiate and worsen each other. And the development of AFib or the development of heart failure in AFib are independent risk factors for poorer outcomes in either patient population. So increased all-cause mortality, increased cardiovascular hospitalization. You can see some of the data behind that the composite outcomes of all-cause mortality and cardiovascular hospitalization are worse in patients who have HFrEF who then develop AFib. So thinking through kind of why these two things tend to come together, there are some shared risk factors, cardiovascular disease, the general risk factors for cardiovascular disease broadly, and then the kind of neurohumoral changes and the structural electrical alterations that are the sort of common substrate of both heart failure and AFib mean that having one predisposes you to the other, and having one also tends to worsen the other. So starting kind of on the left side of the circle, if you think through the heart failure pathway, you have elevated filling pressures, impaired diastole. That leads to increased left atrial pressure, stretch, dilatation, which increases your risk for conduction aberrancy. Then if you move around the circle to sort of the right side, you have rapid ventricular rate, irregular rhythm, and loss of atrial kick. And all those together act to reduce cardiac output and systolic function. And then both of these kind of not exactly inflammatory, but there's changes in ionic and changes at the level of the cell membrane. So I didn't think I'd have to ever think about ryanodine receptors again, but here we are. So changes in calcium homeostasis and for ryanodine receptors and calcium ATPases on the sarcoplasmic reticulum, changes in the way that calcium is managed in myocytes leads to changes in electrical conductivity that predispose both towards heart failure and AFib. And then one thing to know is that exposure to angiotensin 2 and the catecholamine of kind of high inflammatory state leads to cardiac myofibrosis, which then also leads to electrical conduction aberrancies that predispose you more towards arrhythmias. So you have sort of this vicious circle where each of these two problems potentiate each other, and that will be important as we think through why the ways that we treat them kind of work for both or matter for both. Okay. So I just wanted to remind us what are the tenets of guideline-directed medical therapy for heart failure, and pause here and just, I'm hoping, don't have any polls or anything, but I was hoping people could just like shout out or chat what are the aspects of GDMT that tend to have an additional benefit in preventing or reducing the incidence of AFib. Let's see the chat. Hard agree, Lily. Yeah. So I'm seeing a lot of votes for beta blockers. True. So beta blockers have, like we know, have mortality benefits in HFrEF. They also are sort of part of a primary prevention strategy for the development of AFib in patients who have heart failure. I think the things that I learned through doing this that were interesting is that actually ACEs and ARBs have a direct benefit in reducing the incidence and disease burden of AFib in patients with HFrEF, and that is actually also true of MRAs. And based on what I said about the pathophysiology, if you think about angiotensin 2 having a direct impact on cardiac fibrosis, it makes sense that RAS inhibition would have benefits in preventing and reducing the incidence and development of AFib. One thing that I didn't know that I thought was interesting is that there's a fair amount of data that would suggest that the mortality benefits of beta blockers actually only accrue to heart failure patients while they're in sinus rhythm, and that benefit goes away if they're in an irregular rhythm. And that's what this graphic is illustrating, that if you're that even stably rate-controlled AFib in heart failure doesn't provide the same mortality benefit. And then I think everything over the next little bit is going to be about SGLT2. So there are some ongoing trials that are looking into this specific question. So next, I wanted to just go through a review of some of the evidence behind thinking through a rate or a rhythm control strategy for patients who have heart failure and AFib. So looking back to the Affirm trial, 2002, multi-center RCT, we were one of the sites looking at 4,000 patients who were greater than 65 years old with recurrent AFib, and they compared rate control, kind of multiple rate control strategies versus a rhythm control strategy, and showed ultimately that there was no survival benefit difference between the two strategies, but that there was a trend toward increased mortality in rhythm control. Subgroup analysis of this study would suggest that the trend towards increased mortality was particularly true among patients who did not have heart failure. Next is AF-CHF. This is another large study, 1,400 patients. And this actually looked at patients who had both AFib and heart failure with reduced ejection fraction, who were randomized to a rate control versus a rhythm control strategy. And the rhythm control was quite aggressive rhythm control, trying to maintain sinus rhythm with both antiarrhythmic medications and cardioversion. And the study showed that there was no mortality benefit to a rhythm control strategy in patients with comorbid AFib and heart failure. So I think for a little bit, it was sort of settled that there was no strong benefit to rhythm control, and that we didn't need to be particularly aggressive about pursuing that. And then some more recent studies would suggest that there may be more nuance to that than earlier studies suggested. So looking at the AATAC, this is patients with persistent AFib and heart failure with reduced ejection fraction who had an ICD or a CRT in place. And they compared amio versus ablation for rhythm control and essentially showed that ablation was better than medication in increasing AFib-free survival and decreasing hospitalizations and cardiovascular mortality compared to medication. It's a small study, 200 patients, but that was sort of one of the ones that started changing our thinking, I think. And then even more recently, Castle AF, this is, again, small, 360 patients with AFib and heart failure with reduced ejection fraction, comparing ablation versus medical therapy, with medical therapy meaning sort of any combination of a rate or rhythm control strategy, with most patients receiving rhythm control. And basically, the bottom line was that ablation showed improved outcomes in terms of reduced mortality and heart failure hospitalization compared to just medical therapy, and was associated with improving left ventricular EF and AFib-free survival. So next, Cabana 2019. This is just all AFib patients, not specific heart failure patients. Randomized to catheter ablation versus medical therapy rate or rhythm again. And this one didn't actually show a mortality benefit or like serious kind of all-cause or outcomes that you can see there, but it did appear to increase AFib-free survival, and people who received catheter ablations had improved quality of life and seemed to be hospitalized less. And then most recently is East AFNet, which is like a large European study looking at aggressive rhythm control in patients with recently diagnosed AFib, so less than 12 months diagnosed AFib, and comparing them to a rhythm control, kind of, again, broad rhythm control, either medication or ablation or cardioversion versus standard rate control. And they showed that, at least in the subset of population with recently diagnosed AFib, rhythm control is associated with decreased cardiovascular mortality, stroke, hospitalization, and ACS. So I think the big takeaway from the trial is that if you think about patients who have comorbid disease, heart failure, and AFib, they probably do warrant consideration of an earlier and more aggressive rhythm control strategy, particularly ablation. And so I think referring folks in clinic to your friendly neighborhood cardiologist to think about those things sort of early on in their disease course may have more significant benefits for them. On the next slide, we'll talk about sort of why it makes sense that restoring sinus rhythm based on the pathophysiology we talked about before does seem to have benefits in terms of improving ventricular function and decreasing heart failure symptoms. Some of the kind of smaller things to know are that the early trials probably didn't have enough patients who had systolic heart failure, that some of the harms that the rhythm control arms showed were likely due to the side effects of antiarrhythmic medications themselves. And the other thing is that patients who have poor systolic function may not be able to tolerate the beta blockade or the AV nodal blockade that you need to kind of get to goal rate control, because their stroke volume is lower and they're more reliant on rapid heart rate for cardiac output. So yeah, just kind of a review of another view of the pathophysiology we talked about earlier, and just thinking about the fact that even rate-controlled AFib in heart failure has been shown to induce what's an arrhythmia-induced cardiomyopathy, even in patients who have stable rate control, which means that thinking about more aggressive rhythm control strategies and trying to restore and maintain sinus rhythm and preserve sinus rhythm for a larger percentage of the time in patients with comorbid disease makes sense that it would be associated with better outcomes for those patients. These are the 2022 AHA guidelines for comorbid disease. So the first one is patients should be anticoagulated, and that DOACs are preferred for anticoagulation, which I think is old hat for most of us. The AHA guidelines sort of moved up ablation as primarily for symptom and quality of life reasons, but they're sort of an earlier, ablation is an earlier intervention now. And I will say that the European guidelines, so the European Society of Cardiology guidelines, actually have ablation even higher in their recommendations. And they say that if there is concern or consideration that an arrhythmia-induced cardiomyopathy is contributing to decreased systolic function, even in patients who aren't symptomatic, that you should consider ablation early. So just takeaways thinking about these patients in clinic. That adverse cardiac remodeling that occurs with Afib means that arrhythmia-induced cardiomyopathy, even for patients who are stably rate controlled, may contribute to worsening systolic function and poorer outcomes. Patients who have both are likely to benefit more from early rhythm control strategies. And thinking through the pathophysiology of why HFrEF is likely to induce Afib and vice versa, that the medications that we're using for GDMT, particularly RAS inhibition and beta blockade, tend to help prevent Afib. And then there's a graphic that sort of shows some of the principles of managing these two diseases together. So I'll pause there for questions, thinking about sort of the outpatient setting.
Adrian, there's a question that came up from Marcos. If in your review, if you came across what defines early Afib?
Yeah, so that is how the study defined it. So a less than 12-month diagnosis of Afib. Yeah, great question. And I think it looks like Tony was asking a question about ACEs and the mechanism. I think it's the idea being that the direct, because angiotensin tends to induce cardiac fibrosis, which worsens your electrical conduction abnormalities, that having RAS inhibition on board reduces your interstitial fibrosis and kind of provides less substrate for electrical abnormalities. Does that answer the question? Okay, cool. And then just so that it's in one place, if the slides go up somewhere, these are the things that are available to us. So for rate control, kind of beta blockade being first line, with a goal resting heart rate around 70 beats per minute, less than 110 for exertion. DIG as an add-on agent for patients who aren't responsive to kind of maximally tolerated beta blockers. Avoiding calcium channel blockers in patients who have lower ejection fractions because of the inotropy, and then sort of last line for patients who can't achieve adequate rate control with those strategies, thinking about AV nodal ablation and CRT. For rhythm control, amio for your first line, and then dofetilide and sotalol, medications that we see at the VA for inductions, reduce hospitalizations and heart failure, but do need to be initiated inpatient. And then flecainide, contraindicated in heart failure in the setting of ischemic disease, and then again, catheter ablation. And then just thinking about sort of everyone who has these two things, anticoagulation, pretty much everyone should be anticoagulated, kind of hard contraindications notwithstanding. ACEs and ARBs tend, like we talked about, have a role in the primary prevention of Afib in patients with heart failure, as do MRAs appear to, although the data behind that was a little bit less strong. Okay, I think I will go on to the case. Okay, great. This is going faster than I thought it would. I guess I'm either talking too fast or I'm not leaving enough time for people to ask me things. So, our clinical case. So you are on whatever service frightens you the most. Triage calls you and says, you have a straightforward heart failure exacerbation. Don't worry. So we have a 55-year-old gentleman sitting in the emergency department. He has a history of heart failure, some unknown substance use disorder. You hear that he's tachycardic, he's short of breath, he's about 20 pounds up from his dry weight. He's not having current chest pain, his tropes are negative. He doesn't have any concern for an infectious etiology, no known history of COPD, asthma, or CKD. This is a straightforward admit, don't worry, heart failure exacerbation, go on down. So you look through his chart, you find these things. And I think I'd like to pause here and just think about what people think about this and what are the things that sort of come to mind. Or what are you more focused in on?
While people are looking at that, Liam had a question about what percentage of heart failure with reduced ejection fraction patients have their AFib resolved if they have them on all goal-directed medical therapy?
That's a great question, Liam. I actually don't know. Yeah, I don't have a specific answer to that. I think the data that I saw said that the medication categories that we talked about, the ACEs, ARBs, the beta blockers, and the MRAs, like all have some benefit in reducing the burden of AFib. But I didn't see anything that said, like, in all comers on sort of maximally tolerated GDMT, what is the percent reduction in AFib? I don't know that.
I don't know if you're seeing the chat.
I am, yeah.
Yeah, okay, great.
Yeah, so much red. True. Okay, so I think those are all the things that I'm worried about. The heart rate, he's tacking away pretty fast. He is normotensive, which is somewhat reassuring. He's breathing fast. He has a chest X-ray that looks like it makes sense. His troponins are not markedly elevated, which is good. His BNP is very high compared to his baseline. He has a little bit of lactate and unknown, sort of like Lee pointed out, the sodium and the creatinine. Are those, where do those stand relative to his baseline? We don't know. All right. So what are the things as you go down to meet this gentleman in the emergency department that you look forward to the most to learning about him? What are the aspects of his history and exam that are of particular interest to you? Luke, assume he's not on oxygen. Okay. Yeah, I like all of this. Megan, I can do that for you. Okay. So yeah, I think I'm seeing a lot of things that are questions about, is he in sinus, or is he in a tachyarrhythmia? Does he look like he's shocky, like cardiogenic shock? Are his extremities cold or warm? Is he mentating appropriately? Does he have a past medical history of atrial fibrillation or some other arrhythmia that would predispose him to this event? And then can provide an EKG. And yeah, what is the assume no, Mac. Okay. And then, yeah, what's his medical history and what medications does he take? So he has a history of heart failure. He's not entirely sure what. He's been hospitalized a few times outside of our system since he was diagnosed 5 years before. He says, I've been worked up every time, complete workup each time, doc, but he's not really sure what that means. He doesn't know what the etiology of his heart failure is. He says that over the just to make it a little more interesting, let's say it's like December 29th, but over the past 4 or 5 days, he's had some increasing orthopnea. He says, I've had some chest discomfort, maybe some palpitations. My legs are more swollen. I feel like I'm gaining weight. He tried increasing his Lasix because he's actually having a fairly significant weight gain over days to maybe longer, but that didn't help. He doesn't have any infectious signs, symptoms, and he says he takes all his meds every day. In terms of his medical history, so in the chart you see he has a history of heart failure with a reduced ejection fraction. He's got diabetes, he has hypertension, he has a history of meth use. Those are the medications that he's on. So he's on a good GDMT bundle, and he's anticoagulated, and he says he takes all his meds. Doesn't have any allergies, and then you go see him. So he's sitting upright in bed, he's breathing fast, he's diaphoretic, he doesn't look comfortable, but he's mentating appropriately. You listen to his heart, you see the monitor, he is tachycardic to the 130s, 140s, he has an irregular rhythm, you hear a gallop, he has bivascular crackles, he has increased work of breathing, his abdomen is a little bit distended, he has significant lower extremity edema, but like I said, his extremities are warm and he is mentating appropriately. This is his EKG. What is it? Ignore the title of the EKG in the bottom right. So what rhythm is this? Bueller, Bueller, Bueller. Okay, great. All right, great. So Afib. So I'm a big fan of trying to just name the problems. What are the problems that he's presenting with? Ah, oh no. Yeah, exactly. So yeah, the two things that we have someone presenting with acutely decompensated heart failure and AFib with RVR. Which I think that honestly, the entire reason that I picked this as a topic is that this patient scares me. I think about sort of the person who comes in as a kind of, yeah, they're a little bit volume overloaded. They have a heart failure exacerbation, give them a touch of diuresis and send them home. And then either in the ED or by the time they arrive on the floor, they're attacking away and they're irregular. And that's, I think the nuances of that problem was what made me want to do this topic in the first place. So you start the things, you start diuresing him, you're aggressively really repleting his electrolytes, you think about putting him, depending on what sort of level of acuity he's going to, you think about positive pressure. And now I want to focus in on the RVR piece, because I think the idea of managing kind of rate and rhythm in someone who's presenting with acutely decompensated heart failure and RVR is where the meat of this case is. So what are sort of the particular considerations that we have to think about for managing RVR in this situation?
Are you trying to make us say that we shouldn't put him on DILT because we don't want to do that with his heart failure?
Say whatever you want, Max. Say the things that you want to say.
Sorry, nobody's been talking on. I'm just like reading over here on my. Yeah. So I would not put him on DILT if I didn't have to.
Okay, so I think these are all the things. Matt, you said DIG. Marcus mentioned trying to get him towards euvolemia. Lily said don't beta block someone who is acutely exacerbated. Sophie said we can if he's actually taking his anticoagulation regularly, we can think about cardioverting him. Liam and Max are worried that he's kind of trending towards cardiogenic shock. Yeah, and how to think about sort of managing his rate while not bottoming out his cardiac output. These are all the things that I think are exactly what I'm wondering about that. So in terms of sort of the standard management of AFib with RVR in someone who is not acutely decompensated with respect to their heart failure, beta blockers, right? How is that different here? We talked about that. We don't want to beta blockade someone who's in an acute decompensation, although I will get into that a little bit on the next slide. So how do we manage this problem? Kind of co-first line. So I will say, and I forgot to do this at the beginning, I'm sorry. Rigo helped me put together these slide sets, and between the two of us, so big shout out to Rigo, thank you. We looked in a lot of different places, and I don't think that we could find a strong preference one way or the other. It seems like to some degree this is provider preference and comfort. So your first line agents being amio and DIG. Amio, the risk of chemical cardioversion. So ideally they would be anticoagulated first, although in an acute situation, it is what it is. And then the risk of hypotension with giving IV amio, and then digoxin. So kind of one of our oldest medications, takes a little bit of time to act. And then the effect is primarily mediated through vagal tone. So if you have someone who's in a kind of high sympathetic state, like a heart failure exacerbation, less likely to work. And then if you kind of condemn someone to long-term DIG therapy, just knowing that it has a narrow therapeutic window with some nasty side effects. The question of beta blockade is something that is actually pretty interesting. Depending on where you look, it's either okay to use or absolutely contraindicated. So that's, I said second line or none line. The places that say that you can use it would say you need to be really closely monitoring hemodynamics. Think about like an A line, use really small doses and go very slowly, because you're trying to avoid bottoming out their cardiac output by reducing that heart rate that they're requiring in the setting of a low stroke volume. And I think one of the things that's hard to parse in a case like this is to what degree sort of a tachyarrhythmia is contributing to the problem versus is the tachycardia physiologic? And I think, 140 is too fast. The RVR is obviously too fast, but to what degree do you actually want to lower their heart rate to preserve cardiac output in the setting of their volume overload? And then cardioversion, I think a few people mentioned this, if he's truly anticoagulated, or if he has a TEE, and if he's down an ACLS pathway, if he's stops maintaining his blood pressures, then this becomes your first line. Last, again, I'm not going to dive into AV nodal ablation and BiV pacing, but it is there. And then don't put them on a DILT drip. Patient, don't do it. So what are the kind of general pillars of management for folks presenting with RVR and an acute decompensated heart failure? First, the big one is volume management. So diurese. You're trying to reduce congestive symptoms. You're trying to improve perfusion. You're trying to decrease atrial stretch, and you're trying to decrease sympathetic tone. So aggressively diuresing folks to get them at or near euvolemia is likely to have beneficial effects on their heart rate in and of itself. Next is managing electrolyte abnormalities. So particularly magnesium and potassium, because these electrolyte abnormalities can potentiate arrhythmias. So trying to keep things in a happy homeostasis. Anticoagulating, people coming in with AFib, anticoagulate them in case you need to cardiovert and because they should be on anticoagulation long term. And then lastly, thinking about the question of rate versus rhythm control. So in someone who is hemodynamically stable-ish, rate is preferred over rhythm control, with a goal to reduce the heart rate to less than 120 beats per minute, but not further, because again, in the setting of their reduced stroke volume, they are likely relying on some portion of that is a physiologic tachycardia to maintain cardiac output. I will also say that that number seems to differ depending on where you look. But I ended up settling on 120 rather than something lower as being kind of judiciously lowering their heart rate. Yes, agree. I'm glad Riga's here too. Moral support. So the things that we didn't cover in the case that I think are important to think about, because they're the things that people who have AFib and heart failure are going to tend to present with. These things sort of, it's like the quartet of death tends to ride together. So things that you need to worry about, kind of, is this person actually having ACS, or is this an unstable arrhythmia that requires an ACLS pathway? Folks with heart failure often have kidney impairment, which actually narrows your options for therapeutics. People who come in with implanted devices already, and then patients who have either COPD or asthma exacerbations, in which kind of comorbid heart failure and COPD exacerbations and AFib tend to have sort of opposing management strategies. So giving a lot of beta agonists, NABs, are going to tend to potentiate arrhythmias, which is going to worsen cardiac output. And so you end up in sort of a nasty balancing act. So what are the takeaways for acute management here? Again, patients who are tending towards hemodynamic collapse or are in cardiogenic shock are going to get electricity. In terms of the medical management, thinking about amiodarone versus digoxin as being your first line agent. Hard to say which is the preferred agent based on the data I found. It seems to be some degree of what you feel comfortable using and what you have used before, but knowing that you can't use DIG if the person has renal dysfunction, or and that it may have less effect in patients when they're in the midst of an exacerbation in this high sympathetic adrenergic state. Avoiding beta blockade for the most part, if possible, and if you're going to end up doing kind of whiffs of metope, then making sure that you have someone in a situation where you can monitor their hemodynamics really invasively. And then if these things don't work, thinking about early cardioversion to restore sinus rhythm can have benefits in improving cardiac output. And then the other thing that all the guidelines say is, like, if you're certain that this patient has had AFib for less than 12 hours and it's the first time it's ever happened, you can cardiovert them early. I don't know why we say that, because I don't know how, like, who do we know that for? But just know that it's there. Yeah. All right. So for those of us who like mnemonics, just remember that you too can treat HFrEF plus AFib. So just thinking through, again, the principles that we talked about. Cardioversion for anybody who's unstable. Anticoagulating everyone unless there's some strong absolute contraindication. Normalizing fluid balance, so diuresis to achieve euvolemia. Targeting an initial heart rate. This is what I talked about with some differences in the goals, but I would say less than 120. Initiating RAS blockade for the reasons we talked about in terms of sort of the pathophysiology and how those that pathway interacts with worsening AFib. Thinking about early rhythm control for folks who have a newly diagnosed AFib, or in whom you think that AFib is actually the primary driver of their acute decompensation. So in someone who comes in and you're pretty certain that the reason that they're decompensating is because they're not maintaining sinus rhythm, and it seems like even rate control is not going to reduce symptoms or reduce the severity of their exacerbation, then thinking about rhythm control early, the advanced heart failure therapies that I'm not going to talk about, and then making sure that you're covering other diseases and causes. Questions? Great.
Can I stat page you every time I get this patient? As
absolutely. Don't do it. Now you're armed with the mnemonic, Mac. You don't need me. You got it.
Yeah, that's generous. I think I'll rely on your expertise. I appreciate you, and I'll stat page Rigo as well.
That's ideal. Yeah, I actually, please direct all questions and stat pages to Riga. He welcomes them. Yeah, so that's Megan asked a question about how early do you initiate ACEs and ARBs in the setting of a cardiorenal AKI? That's an interesting question that I actually don't have a specific answer to. I didn't look directly into. I know that we hold these medications, and some of the guidelines that I was looking at would say don't. But in the setting of a cardiorenal AKI, it's a little, it's hard. I guess it's hard to say, is this cardiorenal or something else? If you feel certain that it is, there may be some benefit actually in continuing your RAS blockade. But I don't have any specific evidence that would support that. Like, I will look into it. That's a really interesting question. Yeah, Sophie, that's a really good question too. So guidance on the risks of chemical cardioversion with amio when someone hasn't been on anticoagulation. No, because I think honestly, so much of this ends up being kind of expert opinion and just kind of a sense of it's vibes forward medicine. So no specific guidance on when to avoid amio because you're worried about cardioverting them. I think it's if you have concern that there's enough acuity and that you need rate control that you can't otherwise get, then use amio.
Yeah, I don't know if this is, I don't know if this is inappropriate, but I feel like I've seen a lot of attendings do this over the last couple of years of, you're not like, when you start somebody on DIG, you're not really committing them to DIG. You're doing it as like a temporizing measure while you treat the underlying thing. And there's like the less risk for cardioversion. And I just feel like every time I bolus somebody with amio, they end up becoming hypotensive and things like just like cascade out of control. And there's also the risk for cardioversion. And so I kind of agree with Jordan that I just, I don't know. I used Dig the other night in the middle of the night on Hemonc just because it's, I don't know, it works. Yeah.
Yeah. I think that, so I didn't see the original comment from Jordan. Anyway, and so I think that there's an interesting, Megan asked the question about, is it, do you need to do anything to control their rates? And I think that's like, this is where this becomes really hard, is do you think that just by diuresing them to euvolemia that you're going to reduce sort of that atrial stretch and decrease the heart rate that way? I think that's the thing. It's a hard overnight to say like, oh, I'm just going to let them hang out with the heart rates in the 130s, 140s, and I'm not going to try and provide any rate control. But it is a reasonable question. And I think the other thing is, if you think that someone sort of recently converted to an irregular rhythm, like this guy maybe 5 days ago went into maybe a first or maybe a recurrent episode of Afib, if that the irregular rhythm is driving their decompensation, and even if you get them sort of stably rate controlled, that they may not actually have that much symptomatic improvement. This is kind of where there's a lot of equivocation, and it becomes sort of hard to think through. So I certainly don't have most of the answers, but hopefully you guys derive some benefit from seeing your options. And Roshan, I think so. Roshan said something that I think is worth remembering, that if someone is going back and forth into AFib, like how different is that from you chemically cardioverting? The only thing being that you would feel really bad if they threw a cardioembolic stroke because of you. But it's true, they are sort of cardioverting themselves in and out. And so what is the sort of the increased risk of you doing it versus what's happening for them physiologically on kind of a day-to-day basis it's an interesting question.
Yeah, and I also feel like the way that I've heard the cardiologists, logic themselves, or I guess like make themselves feel better about that concern is like it's a quote unquote annualized risk. So yes, you're definitely like making things worse when you like actively do something, but it's like the lesser of two evils at that point.
Oh yeah, definitely, Jordan. There will be some trial with a name that that the cardiologist spent a year thinking of, and then designed the study around the name, and it will tell us that what we've been doing hitherto was not good.
Well, Adrian, this might be a good place to pause. I think the interns have mega report coming on in about 5 minutes, so give them a chance to take a break. Amazing discussion and presentation. Thank you, Adrian, and guest appearance from Rigo. I think joining us from California. But really appreciate it. I'm sorry that I missed the first talks today. I had unfortunately another meeting, but I'm here for the rest of academic half day. Let's take a 5-minute break. I'm gonna put the link to intern mega report in the chat for folks. And then seniors, if you come back at 10:45, we'll get started with our last talk of the day from Arjun. So here is the intern mega report link. And interns, we'll miss you. Have a good next session and a good rest of your day.